This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
What I'd like to do is first start off with a little bit of historical perspective, then talk a little bit about mechanisms of chronic pain. How does it develop? Finally, I'd like to talk about one older technique and one newer technique, deep brain stimulation and motor cortex stimulation, how they work, what their indications are, and what the outcomes are from surgery. Pain is obviously one of the oldest human afflictions, and there are written and unwritten records from antiquity of pain and its various treatments. In about 500 BC, the ancient Egyptians felt that pain was due to demons, and that they needed to pray to their deities in order to be alleviated from pain. So pain was mainly treated not by physicians, but instead by priests. And the idea here was to try to drive out the evil spirits by elevating the intensity of the stimuli. So they applied such things as heat, cold, and electrical stimulation, and they did this with electrical fish. And here you can see this is a stone cutting from ancient Egypt showing a boat on the river Nile out catching electrical fish to use for pain treatment. Unfortunately, pain treatment languished for the next several hundred years until the great physician Galen came along in approximately 150 AD. He made many advancements in both anatomy and physiology to find the anatomy of the cranial and spinal nerves. He came up with a complex theory of sensation, well, a little bit too complex. There were some errors in that which unfortunately persisted for many years, and felt that the brain rather than the heart was the center of perception, an important piece of information. He actually reinstituted the use of electric fish for pain and once again redemonstrated that they were effective and noted some numbness and paresthesias or tingling in the area where the electric fish were applied. So clearly this was a real physiological effect and not just something magical. Once again, pain treatment languished for many years, in fact many centuries, until Descartes in the 1600s carried on the Galenic tradition of defining anatomy and physiology, focusing on the brain as the seat of sensation and motor function. And in his explanation of how these systems worked, he felt that nerves were perhaps strings which were pulled when they became irritated, for this example, in a fire, and that these strings would then pull open a valve within the cerebral ventricles, and that the fluid would be released and would cause the sensation of pain to occur. Well, he did have one thing right, and that's that there is a connection between the peripheral portions of the body and the brain, but exactly how that works, I'm afraid he didn't get the details quite right. In terms of electricity, though, there was a huge debate between Galvani and Volta in the 1800s. These two investigators, one of whom was a physicist, one of whom was a physician, both demonstrated electric currents in living organisms, but felt that they were due to different things. Galvani felt that there was an intrinsic animal electricity, that the living body had an electricity that caused its muscles to move, whereas Volta thought that there was no intrinsic electricity and that everything was extrinsic, and he created the first battery and demonstrated muscle contractions with electric current. Well, they were both right. There is an intrinsic electricity within the body, and it can be affected by external stimuli. So because of these two giants of electrical investigation, you can see here Galvani's lab here with frog legs dissected and demonstrating this, what he felt was the intrinsic electrical generator within the body of the animal. In the 19th century, numerous investigators pursued electrical analgesia. This is one of these inventions. Unfortunately, these fell into disuse due to variable results. Many quacks use these electrical devices, some to fairly good result, but others not. And of course, through this time, people tried to understand what it was that was causing pain and what it was that was causing the relief of pain with electrical stimulation. And there were a number of conflicting theories during this time. Well, in the 20th century, there was an explosion of information regarding anatomy and physiology. We now began to understand for the first time the true basis of pain and of pain treatment. We started thinking about electrical circuits, and these became commonplace. So it was quite natural to begin to think of circuit diagrams as they applied to the nervous system. And a whole raft of theories then appeared, including specificity theory, where labeled lines of touch and pain sensation came into the nervous system unchanged. Summation theory, where different types of stimuli summated to go up to the brain. Reverberatory circuits, meaning that pain could get trapped in these reverberations. Interaction theory, with many different types of neurons and nerve cells interacting. All of these theories came into play, and many of them still have some validity today. But really, when we think about it, how does pain get to the brain? How do we take a peripheral stimulus and translate it into something that we feel is painful? Certainly not because of a string opening a valve in our brains. Well, the main way that pain gets to the brain, and we don't call it pain until it gets to the brain, because at this point it's still called nociception, which merely means the perception of a noxious or painful stimulus. It's not yet become pain until we attach some emotional meaning to it. This is called the spinothalamic tract, which is an area of the spinal cord which connects the spinal cord, thus the spinal part, and the thalamic part, the thalamus, which is a relay station deep in the brain. The spinothalamic tract mainly runs on the opposite side. It conducts impulses concerned with both pain and temperature sensation. And it's thought to consist of two major divisions. And you can see here where these pain fibers originate. This is a cross-section of the spinal cord. Impulses from the peripheral nerves come in here. There are connections which are made here. These fibers cross and then go up to the brain in these two separate systems. One, what's called the paleospinothalamic tract, or the older spinothalamic tract, is present in older animals, such as reptiles. It's a complex pathway, multisynaptic, meaning that there are many nerve cells which go from the periphery centrally and up to the brain. Lots and lots of different connections, and these connections are made through the more medial, or closer to the midline, portions of this relay station, the thalamus. Now, there are projections from this relay station to limbic structures. These are structures that are involved with emotion and with the general arousal of the organism. And it's felt that this system may subserve more poorly localized pain and may mediate the emotional aspect of pain. Contrast this with the newer system, the neospinothalamic tract, which is now present in higher vertebrates and primates. This is more lateral, meaning that it's further from the midline, and projects very exquisitely and specifically to the brain surface itself. So it's felt that this system may mediate the localization of pain. So we really have two separate systems here. We have one which is more of an intensity monitor, and we have one which tells the organism, hey, here's where the pain is, you need to do something about this and avoid it. Both of these systems come up to a part of the brain called the thalamus, and this is interesting to us as neurosurgeons, because if you want to affect a circuit, you'd like to go to the relay. If you're going to affect the phone system, you want to go to the phone company where all the phone lines come together. So the thalamus is like a big phone trunk, and that's where we want to get to if we're going to be intervening in pain. And as we talked about, there are medial, or closer to the midline portions, called the centromedian nucleus, which relay emotional responses to different portions of the brain and are connected diffusely with the brain. So not specifically, but diffusely. And more lateral portions, which relay somatotopic, or in accordance to the body map, sensations to those portions of the brain which allow for discrimination. And these are quite specific and mapped to the body. The thalamus is this knob of tissue right here, which sits on top of the brainstem. So the spinal cord comes up through the skull, so the skull base is here, and then this is all inside the skull. The cerebellum, or little brain, sits right here. The main portion of the brain is up here, and the thalamus sits right in the middle. There are connections from many different portions of the brain to the thalamus and back again, from areas of the brainstem, from areas of the body. But the ones that we're mainly interested in here are this more medial portion, these two parts right here, which project more to the emotional part of the brain, and these parts here, which project to the more sensory portion of the brain, and that's demonstrated here. People don't really know yet what the role of the brain, the rind of the brain, the cortex, is in the perception of pain. It's felt that it probably serves a discriminative function. It's difficult to generate pain by cortical stimulation unless you already have chronic pain. So in normal people, stimulating the brain doesn't necessarily cause pain. But we do know that there are certain parts of the brain that light up in chronic pain states. And one of the biggest areas is right here. It's called the anterior cingulate. This part, if we do functional imaging, tends to be very active in chronic pain. There's also a part deep inside the brain, within the folds here, called the insula, which is also quite active in pain. So right now, there's a large amount of research being focused on teasing out the components of pain. Okay, so just to summarize what we've said so far, this is what a diagram of the system looks like. So from the spinal cord, there's circuitry within the dorsal horn, which is the area of the spinal cord where all these inputs come in, and that there are neurons there, or nerve cells. Then there are the two separate pathways, as we said, the medial and the lateral pathway. And the lateral pathway, as we said, seems to serve more of a sensory or discriminative role, which allows us to analyze the spatiotemporal aspects of the sensation. And then the more medial system seems to be more of an intensity monitor, or a motivational affective system. And then finally, this will be important later on, we're going to talk a little bit about these descending inhibition systems. So there are systems within the brain which are built in, which can inhibit pain. And these, people are very familiar with these. If you know about stories of soldiers who have been hit by shrapnel, or have had arms or legs blown off, and don't necessarily complain of pain. Football players may be terribly injured and not have much pain. People who have a strong emotional component to the situation that they're in may activate these descending systems which can inhibit pain. So that's what the normal system looks like. Well, what happens in the abnormal situation? What causes a good sensation? Pain is a good sensation because it allows us to avoid bad things and go towards good things. What causes that to become chronic? Well, there are really a couple different types of chronic pain. The first type is called nociceptive pain. Nociceptive meaning reception of pain signals. And this presumes that you have an intact nervous system. It's, quote, normal pain from inflammation, tissue damage, or chronic irritation. And examples of this could include arthritis or cancer pain. It's felt as an aching, sharp pain which is related to tissue irritation, can be a pressure type of pain, but often has a mechanical component to it. And this is just an illustration of one theory of what might happen in chronic nociceptive pain. Injury occurs to the tissue, and when that injury occurs, there are substances that are released. Ions, like potassium ions, other substances like prostaglandins or bradykinins. All of these are inflammatory substances that are released into the tissue. And this is a diagram of a bare nerve ending, which is the type of nerve ending that transduces pain. And these go then to the spinal cord and then up to the brain. Now, in the chronic situation, these nerve terminals actually secrete substances. One of the major ones is called substance P, P standing for pain. When substance P is secreted, it causes platelets to release serotonin, mast cells to release histamine, and it causes leakiness of blood vessels with release of bradykinin. So these are, in essence, vicious cycles that can occur within the tissue, causing this ongoing inflammatory reaction. Well, there's another type of pain as well, and that can be distinguished from nociceptive pain, and it's called neuropathic pain. Neuropathic pain arises from damage to the nervous system, and it has a different sort of character. It's usually described as burning or lancinating or stabbing or lightning-like. It can be very difficult to describe. It can be called electrical. A lot of times patients have a hard time putting exact words to it. Some examples of this can be, the classic one is trigeminal neuralgia, but also diabetic neuropathy, postherpetic neuralgia, nerve injury following spine surgery, post-stroke pain. Many types of damage to the nervous system can be classified as neuropathic pain. And the mechanisms involved in this are many. When nerves are damaged, peripheral nerves are damaged, they can discharge spontaneously. They can be very sensitive to mechanical stimuli. And there can be crosstalk. It's like having the insulation on wires worn away, and then there can be short-circuiting between the two. The same sort of thing happens in nerve fibers. As we move up to the spinal cord, there are many different types of changes in the circuitry that can occur here. Receptive field changes, gene expression can be changed, the receptor physiology can be changed, and there can be hypersensitivity within this region as well. As we move up to the brain, many of these same changes can happen. And it's really the brain that we're going to be focusing on next. What we're going to see next is a patient describing a type of pain that he has, which is a neuropathic type of pain. And we'll be sort of zooming in to see where this pain might potentially originate within his nervous system.
Short, sound, aching, burn, pain, different variations, all types of pain. Constant pain, never goes away. It's there 24/7.
So as we look at this particular patient's brain, it's going to look anatomically like anybody else's, but this is the thalamus. This structure here, this relay station, and within the thalamus are the neurons, these brain cells which receive different types of inputs which can be abnormal, can be abnormally firing, which can have abnormal inputs. And this is an area that we're intensely interested in. This is where the next thing we're going to talk about, deep brain stimulation, comes into play. Putting a stimulating electrode in amongst those abnormally firing neurons in order to affect chronic pain. So there are two major targets within the thalamus, within that relay station in the brain. The first one is called, well, this is the lateral one that we talked about, the VPL-VPM complex, which is the specific relay. This is probably the most common target for deep brain stimulation for pain. Deep brain stimulation has been around for, probably 50 years, although it's not been until the past decade or so that we've had fully implantable systems to be able to use for patients with pain. And this interferes with the relay through the lateral system, the one which is more specific or discriminative. There have also been attempts made at stimulating the more medial structures, the non-specific system, which interferes with the relay through the medial system, or the more affective system, the more emotional system. So what do the nerve cells in this, the brain cells in this region, look like, and how do they behave? Well, some experiments have been done with animals, and we find that there are particular cells within this complex that can respond to various types of stimuli. So here you see that this unshaded area here is a non-receptive area, and the shaded area is an area in which this cell responds to various stimuli, and this is in a monkey. So by brushing this region, you get responses at about 60 spikes per second, with pressure about 60, with pinching about 120, and with squeezing much higher, so that there's a graded response to stimulation of these brain cells. In humans, the same sort of thing has been found. Some pain-specific neurons or brain cells have been found. They're both wide dynamic range, meaning they respond to many different types of stimuli, as well as pain-specific. And stimulating with a tiny electrode in these areas can evoke a sensation of pain. It appears that these responses undergo plastic changes in chronic pain, meaning that more and more neurons begin behaving in this abnormal way. So the brain actually learns to have pain. There also may be representation of abdominal types of pain or visceral pain in these regions. Targeting this zone, it's between 13 and 15 millimeters lateral to the midline. We use micro-recording and stimulation, which I'll show you in a minute, and we actually map out the receptive fields, as we showed with that monkey experiment, in our human patients. And then we introduce an electrode to that point, and this is a diagram of what that electrode looks like. So how do we actually do this? Well, we have to use a technique that allows us to get into a precise region of the brain in three-dimensional XYZ space. So we use an old technique which was first developed around the turn of the century for use in laboratory animals called stereotactic technique. In this technique, we superimpose a Cartesian XYZ coordinate system on the brain. So any point within that system can be specifically defined. Traditionally, this is done with something called a stereotactic frame. And this attaches to the head with 4 pins that screw into the skull. This produces sort of a squeezing pressure sensation. It's uncomfortable to wear this for any length of time because your head is suspended in midair. But what this does allow for us to do is to use these slides to go in the X, the Y, and the Z dimension in order to precisely position a probe at any point within the brain. In order to do this, we need some method of knowing exactly where we are. So for this, we use what's called a localizer system, a fiducial localizer system, with 6 upright rods and 3 diagonal rods. As we take scans, CT scans and MRI scans through the brain, the upright rods appear in the same positions, whereas the diagonal rods move. And by knowing the mathematical relationship between all of the rods, we can precisely calculate quite nicely where we are within that space. Here you see a patient enjoying a head frame application. This is, as you can tell, a fairly noxious procedure, and patients don't like it very much. So one of my main areas of research has been to eliminate the frame, and now we actually do this in a frameless way. We've been able to eliminate the stereotactic frame. We still have to have reference markers, for which we use small screws. We've demonstrated that the accuracy is equivalent, and it's been really remarkable how much increase in comfort the patients have had during these operations, for which they have to be awake for several hours. And instead of having their head suspended in a frame, they're able to lay comfortably, they're able to move around, and it actually helps to shorten the procedure time. So this is how we do that. Most patients compare it to a trip to the dentist. You get a little bit of numbing, you get a little bit of drilling, and then it's over. And we put these small markers, you can see one of them here, in with a little bit of local anesthetic and an electric drill. And we've asked patients who have had both procedures done which one they would prefer, and they all say that this one is much less uncomfortable than frame placement. We then obtain images of the patient. Now, we do an MRI scan for its superior tissue definition prior to placing those markers. The problem with MRI is that there can be distortions, and obviously if you're trying to get it to a precise point in the brain, distortion is something you absolutely don't want. So that's why we perform a CT scan. CT is not prone to distortions, but the tissue definition is not as good. In order to get the best of both worlds, we fuse the 2 images together, and that's what this looks like. Here we have a commercial software program which allows us to take the CT scan, which you see here, and the MR scan, which you can see cut away here. You can see how much better you can define the gray and white matter of the brain and small details, and you can also see how good the result is of matching these 2 up with this automated algorithm. We then target based on our computerized landmarks and scale atlases and other things to fit the patient anatomy. We can also integrate functional imaging such as PET scans into our planning software. So this is a screenshot from the planning software showing a 3-dimensional representation of the patient's head. Here you can see these are the markers with little protectors on them. You can see our planned trajectory where we'd like to go in the thalamus. And you can see a PET scan which has been superimposed here showing that there is asymmetry between the 2 sides, and that this side is actually less active than the opposite side in the region that we're going to be targeting. So quite an interesting finding, and really helped to get us to our precise target. We then bring the patient into the operating room. You can see there's a padded headrest that they wear. These are the markers, and those markers then correspond very precisely to the 3-dimensional reconstruction in the computer system. So each of these markers has, in real space, what we call surgical space, has a corresponding spot in image space. We then attach a reference, and this is just a strap that goes around the head. These are soft, cushioned sort of suction cups that allow this to sit on the head. These reflective spheres are tracked by cameras. There are 2 cameras which are a distance away and can track these through 3-dimensional space. And by then touching each of these points in turn in the patient, and then touching each of those points on the CT scan, we now tell the computer that this real space corresponds to this image space, and we now have X-ray vision. We're now able to very precisely localize our entry point, which we chose on the computer, because every time we move our instrument on the patient, we're moving a virtual instrument in the computer system, and those are one-to-one with one-to-one accuracy. Once we've opened and redraped, then we re-register. And this just shows the type of accuracy we can get. These spheres are about 4 millimeters in diameter, and you can see that we're precisely in the center of each sphere. So our accuracy of localization is less than 1 millimeter. Then reassemble this tower, and this is, again, attached to the patient's head so they can have free movement. They can move in any way they want to. This area is anesthetized, and the brain itself feels no pain during surgery. We then use a small device to align the system. You can see me looking at the computer screen here, and the task that I'm accomplishing is a sort of a Nintendo video game where I take this aim point and this aiming reticle and I move it over the target. Once we've done that, then we attach a micro drive, which is this device that you see here. And this is all made of plastic. It's quite light, and it allows us to introduce a hair-fine electrode deep into the brain. And this allows us to essentially listen to those brain cells and hear what they're saying to us. We use electrodes which are made either of tungsten or platinum iridium alloy. We tend to like the platinum iridium because tungsten, when electrically stimulated, will plate. We don't want electroplating in the brain, and platinum iridium is much less reactive. The tip is between 1 and 10 microns in diameter. A micron is 1,000th of a millimeter. So these are extremely small electrodes, finer than a human hair. And our objectives are to identify the brain cells and listen to their different firing patterns. The thalamus has very characteristic firing, which I'll show you quite soon. And then search for cells driven by sensory input. So once again, to zoom into the brain here, right into the region where those cells live in the thalamus, and then to introduce a very fine electrode very close to these cells so that we can listen into their conversations. And when we record this on a computer screen, this is what it looks like. So each time this neuron fires, each time it gets a number of inputs and then reaches a threshold value, it creates an electrical impulse, which actually these impulses go down. So this usually gets its input from the brain surface and then sends its output down to other areas of the brain. And then during the course of surgery, we can track the position of that electrode and overlay it on where we think we are in terms of the various nuclear groups, the various different areas of the thalamus. So what you're going to see next is actually intraoperative footage. You're going to see movies from in the operating room. My assistant, Dr. Helen Bronte-Stewart, who's a neurologist here at Stanford, is going to be testing a patient who's having this procedure done. And what you'll see is that we have located cells which are very responsive to various types of stimuli. In this first, in the first video, you'll see that this is very sensitive to paintbrush just on the thumb, not on these fingers. Just on that surface of the thumb. And we record that on this. This is our recording rack with amplifiers, filters, and then a display program, which is all run by a computer, so that we can identify the areas which correspond with that individual patient's pain. Here you can see a cell sensitive to pressure. Just on the pad of the thumb. And you saw not to brushing, but just to pressure. And then as we move the electrode deeper, we can continue to map out the structure of the deep nucleus and find cells responsive to face. You can hear the neuron responding. So once we've established our map, then we place the stimulator. And again, this is what that looks like. Right now, Medtronic is the only company that manufactures these. This is what they call their 3387 electrode, which has 4 exposed contacts, 1.5 millimeters long and spaced 1.5 millimeters apart. So this whole thing is 10.5 millimeters long. Our usual stimulation parameters are pulse widths of between 90 and 120 milliseconds. So these are pulses of electrical energy that get administered continuously with rates anywhere between 50 and 130 cycles per second. And voltages, which I didn't put up here, but the voltages are in the range of anywhere between about 1 volt to about 3.5 volts. Intraoperatively, during surgery, we need to evaluate side effects. We need to make sure that there's no dizziness, no double vision, no muscle contractions, no other problems with the administration of the stimulation. And then finally, once we've found our location, we put that stimulator into this region of the thalamus, which is responsive to those stimuli. Finally, we anchor the lead in place. Here you can see there's a little plastic cap that we use. The lead comes out, there's a clip which goes in, holds the lead firmly. We put it into a slot and put a plastic cap on. So there's a little bump underneath the scalp. It's about 3 millimeters high. The final step in this procedure is to place the pulse generator or the pacemaker. This is usually done as a staged procedure. It's placed usually 1 to 2 weeks after we put the lead in. The reason we do this is we want to let the brain recover. We want to allow resolution of inflammation or any tissue reaction that may be going on. And then we usually activate the system about a month after we put the leads in. And this is what the whole system looks like. Here's that deep brain stimulation lead, again being held. This one is actually a 3389, which has tighter contact spacing, but you can see that the diameter of the lead is small, 1.2 millimeters. And this is what the pacemaker looks like. And the entire system, once it's implanted, looks something like this, with the pacemaker implanted beneath the collarbone here, the wires running up underneath the skin, connecting to the lead, which goes into the brain, and then there's a connector which sits just behind the ear. So that's one approach to stimulating the brain for pain, but we talked a little bit earlier, I don't know if you remember or not, about systems which are involved in our own body's anti-pain mechanisms. They've been extensively studied in laboratory animals, and in fact, stimulation of these regions can produce profound decrease in pain, so profound that people have performed abdominal surgery on rats with only stimulation of these brain regions. It appears to be opioid mediated, which means that medications such as morphine and others like it act on the same areas, and it's reversible by blockers of morphine. It's also blocked by lesions of the spinal cord, which means that, as we saw before, there are pathways that go from the brain back down to the spinal cord in order to shut off pain. This system is located quite deep in the brain, right down in the brainstem. In fact, there are a number of different areas which are involved in this, including the amygdala, hypothalamus, these midline areas, these collections of brain cells, the nucleus briefe magnus, the reticular formation, and the periaqueductal gray. This periaqueductal gray region is the main region for stimulation, and it serves as sort of one of the master regulators of some of these other nuclei. And because of its accessible location and because of the demonstration in rats of the anesthesia that can be achieved, this is a good region for the placement of deep brain stimulation electrodes. The thalamus actually lies right about here, so we're very close to the thalamus, more medial and more deep. So what are the clinical results of deep brain stimulation? Well, one of the problems with deep brain stimulation, and one of the reasons that it is no longer approved by the Food and Drug Administration, is that there have been very few good studies of the outcomes. Robert Levy from Northwestern University, whom I know well, reviewed this for me in a publication in 2003, writing about deep brain stimulation for the treatment of intractable pain over about the past 50 years, and reviewed all of the studies that have been published. And it's interesting that, first off, the long-term success is quite variable depending on the study. Second, the type of pain makes a difference, and the target makes a difference. So, for example, that thalamic target for nociceptive pain, 0% effective. So people who have pain like cancer pain or inflammation pain or arthritis pain, if you put an electrode in the thalamus, none of them will get better. On the other hand, if you stimulate the periventricular gray or periaqueductal gray, which is where the opioid-like analgesia comes from, about 60% of them will get significant pain relief. And that sort of matches what we think of when we think of that type of pain. If you take morphine, it gets better. If you stimulate that region of the brain, it gets better. Well, what about neuropathic pain, pain from damage to the nervous system? Well, it's just about the opposite. It's flipped just about the other way around. Although about 23% of patients will get significant pain relief from this opioid-mediated system, from the morphine-like system, means about 77% won't. And that, again, matches clinically what we see with trying to give morphine to people with neuropathic pain. It often just doesn't work. By contrast, stimulating the thalamus, about 56% of patients will get good relief. And because of this, everybody I've ever implanted gets both targets, as you can see right here. And you can see that the periventricular gray matter, which is adjacent and more superficial to the periaqueductal gray, lies pretty darn close to our target in the lateral thalamus. So by putting one electrode medial and one lateral, we can cover both regions. And all of my patients with implanted deep brain stimulators are still using those stimulators, in some cases 5 or 6 years later. And everybody's getting some pain relief, although, as you can see from these numbers, it may or may not be great pain relief. So deep brain stimulation is no longer available. Insurance companies don't pay for it. You can do it, but it requires either people paying for it themselves or holding the director of the insurance company nearly at gunpoint in order to get it paid for. Well, what are some other options? In Europe and in Japan, stimulation of an area called the motor cortex has been used. And this is a little bit strange because the motor cortex is the area of the brain that controls movement. And it's adjacent to the area that controls sensation. You would naturally expect that if you stimulated the area that controlled sensation, you would improve pain. Untrue. If you stimulate that area in a patient with chronic pain, you can actually make the pain worse. It was by serendipity, which is how most great scientific discoveries are made, that it was discovered that stimulation of the motor cortex actually helps pain. And this was discovered by a Japanese neurosurgeon by the name of Tsubukawa. So motor cortex stimulation is actually stimulation of the surface of the brain. And you can see here our patient, and you can now barely make out the surgical scar, and the postoperative X-ray tells the tale of where those stimulation electrodes are placed. So these are what the electrodes look like, again, currently made only by one manufacturer, Medtronic, and this is how those lie over the surface of the brain. So here again you can see this is the motor cortex, this is the sensory cortex, and the active electrodes are lying along the motor cortex of the brain. The first series, as I said, was reported by Tsubukawa in 1991. This is the Japanese neurosurgeon that discovered the sort of strange paradox that stimulating the motor cortex is actually effective for pain. And we put these leads outside. We don't put them on the surface of the brain usually. We put them over the covering of the brain because the stimulation can go through that tough outer covering. At this point, there have been probably close to 35 or 40 published reports. The number of patients is growing all the time and is now probably over 300, with efficacy of between 50 and 78%. So thus far, the results look pretty good. The idea is that you intermittently stimulate. Unlike deep brain stimulation, which is continuous, we usually stimulate this area. And here you can see a patient with a functional MRI scan. This is the activation area for the hand. She had facial pain, so we put the electrodes in the face area, which is going to be just lateral to the hand area. And she's still getting excellent relief from these electrodes. Her stimulation paradigm is 20 minutes on, 15 minutes off, and that continuously cycles throughout the day. The pacemaker does that for her. We can do this because there's a halo effect, that once you've stopped stimulation, the pain relief carries over and continues despite the fact that you're not currently stimulating the brain. We target this in pretty much the same way we target the deep brain stimulators, although we do try to use functional imaging. This is an image obtained here at Stanford of a sensory motor activation task. You can very nicely make out the divider between the sensory area back here and the motor area. This will be our target zone here in the motor cortex. And we can overlay that, so we can take that activation area and incorporate that into our surgical navigation system. So this is that same software that you saw being used for targeting the deep brain stimulators, now being used for targeting the cortical surface. And we can do reconstructions, which once again show very nicely the divider, what's called the central sulcus, the central area of the brain. Sensory is back here, motor is back here, and this is our area right here that we're going to be stimulating in the hand region of activation. And we use that same wand system, which is tracked by cameras, in order to precisely localize our target point. Motor cortex stimulation is an emerging technique. It's not yet firmly established. Many insurance companies are paying for it because it has shown some efficacy. Unfortunately, there have been few patients studied. But it does offer hope for patients who have intractable pain of many types. The success rate seems to be somewhere close to 50% for most types of pain. And most of the data has been obtained in two main areas, which I'll look at separately. First, post-stroke pain. So people who have had strokes deep in the brain will often develop a burning, persistent, agonizing pain, which is untreatable by any other method. So for them, any kind of pain relief would be worthwhile. And neuropathic facial pain. This is not trigeminal neuralgia or other types of facial pain. It's pain which arises from damage to the nerves in the face, and which, again, constant, agonizing, very difficult to deal with. So these are two very difficult to treat areas which motor cortex stimulation has shown some promise for. So first, post-stroke pain. Well, our intrepid Japanese neurosurgeon Tsubokawa in 1991 wrote the first report of motor cortex stimulation for central pain or post-stroke pain. In these patients who had had strokes in the thalamus, which caused constant burning pain, 5 of 11 had what he deemed satisfactory relief. Well, that's pretty good, because those are 5 patients who otherwise would have been suffering. Although it's less than 50% in terms of the success rate. So others have tried to reproduce this, and I'll talk about a few of these studies. Meyerson in 1993 tried this on 3 patients, all of whom failed. Another Japanese neurosurgeon, Hosobuchi, had 2 out of 3 failures at 2 to 6 months. And a French neurosurgeon, Jean-Paul Nguyen, in 1997 published on 5 patients with a mean follow-up of 2 years. 2 patients had less than 40% pain relief, 1 had 40 to 60% pain relief, and 2 had 60 to 80%. A couple more studies. This study from '99, 4 patients with 30, 40, 50, and 100% pain relief. And one more Japanese study, 6 patients, 1 excellent, 2 fair, and 4 failures. Interestingly, it's thought that perhaps there may be some predictive value of intravenous medications to try to predict whether this will help or not. So the verdict, if I'm Siskel and Ebert, on post-stroke pain, 1 thumbs up, 1 thumbs down. It works for some patients, and for some it doesn't. But the caveat here is that there are few other treatments for this condition. So there's really not much to do for these patients. Anything that could help would be worthwhile. What about the second condition I mentioned, neuropathic facial pain? This is a special interest of mine. I tend to see quite a few patients with this because some patients with trigeminal neuralgia following treatment, whether it be a destructive treatment or other type of surgery, may have chronic persistent pain. And again, this is very difficult to treat. So I was quite interested to read this study by Meyerson on 10 patients with neuropathic pain, 5 of which were facial. All 5 of them got greater than 50% pain relief in follow-up of over 2 years in some cases. Another study published in '97 in the European Journal of Neurosurgery, again by Jean-Paul Nguyen, 7 patients with facial pain following various types of trauma to the nerves. All patients had satisfactory to excellent relief in follow-up of, in some cases, more than 3 years. And finally, Abel et al. In '97, 7 patients with facial pain of varying etiologies. 6 of 7 initially got good to excellent relief. Only 3 of 6, 50%, had excellent pain relief at last follow-up, with follow-up of 5 to 24 months. And I would say, certainly in my experience, this is probably closer to the truth, that about 50% of the patients will get adequate pain relief, but sometimes in these patients who lose pain relief over the long term, reprogramming their stimulators can make a big difference and can recapture their pain relief. So I guess I have to give this one 2 thumbs up. This is probably a pretty good idea for patients with neuropathic facial pain. So with that, I think I'll wrap up. What have we learned tonight? Well, I think you would agree with me that motor cortex stimulation is effective for facial pain and also possibly for this type of pain called deafferentation pain, which is also called post-stroke pain. Deep brain stimulation can be very effective depending on the etiology and depending on the target. So different targets for different types of pain. New targets now are emerging based on our greater understanding of the brain, especially with deep brain stimulation. We're not anymore really limited to two targets. As we've explored some of these circuits, as we've explored some of the ways in which pain occurs in animals and in humans, we're expanding our knowledge and we're really learning more about all of the connections and where we might be able to stimulate those connections. And we may come up with much more effective treatments in the very near future. And finally, I think what this really indicates is that we need more research. And so part of my ongoing work is to design clinical trials to look at the outcomes from these various procedures in the long term. So with that, I'll finish and take any questions. Thank you very much. Mortality rate is extremely low. For both types of surgery, the mortality rate is less than 1%. The morbidity rate, meaning the complication rate, is somewhere around 5%. And those complications can include things like infection, hemorrhage, stimulation side effects, which you can't program around, or mechanical complications with the system, which can include breakage or migration or other problems. So the mortality is quite low. Morbidity is still low, but is real. So there are some risks to the surgery. Sample size for deep brain stimulation. Hundreds of patients, although I can't give you an exact sample size. There have been, probably 100 or so studies published in the past several decades. And it's always difficult to tell because some patients are double reported. They end up in several different studies, so it's hard to say for sure, but several hundred. So the question is, we showed some mechanisms of how pain is transmitted. What are the mechanisms of how the stimulators work? And we have to say we know a little bit, but we don't know a lot. I took about 30 slides out of the presentation talking about mechanisms of action, which I'm very interested in, but I didn't want to go into in depth. But let me just touch on a few. One of them is probably activation of inhibitory pathways, sort of these descending inhibitory pathways, probably true with motor cortex stimulation. There could be a jamming effect. In other words, you're jamming abnormal signals that are coming through the neurons by just replacing those abnormal signals with a constant noise level. We could be activating areas downstream so that we might be activating those brain cells, and then they're activating other areas which are in turn activating other areas beyond just the local effect. So there are a number of different postulated mechanisms, and all of those are being actively investigated. So each year at our scientific conferences, somebody presents new data, bringing us closer to understanding how these things actually work. So the question is regarding FDA approval of motor cortex stimulation versus deep brain stimulation. Well, I have to clarify, motor cortex stimulation is not approved by the FDA currently. It's not FDA approved. However, California Medicare pays for it. There's precedent for this. When we first started doing deep brain stimulation for Parkinson's disease, there was such efficacy demonstrated that Medicare decided that those patients were doing so well that they deserved to get the procedure even though it had not yet been approved by the FDA. And I think that's the stage we're at right now with motor cortex stimulation. What I'm embarking on right now is trying to get federal NIH funding to really do an organized study of motor cortex stimulation rather than just a case report here and a case report there. Actually put 5 centers together, have everybody do things the same way, evaluate the patients carefully pre and post surgery, and really make a case to the FDA that, hey, this should either be approved or it shouldn't be. What happened with deep brain stimulation was that all of these poorly designed studies were reviewed. The manufacturer of the electrodes, Medtronic, decided that the data was too poor for them to actually go forward and apply for a formal FDA approval, and that the patient population was too small. And because of that, because of their outright refusal to do that, the FDA said, well, in that case, we're we're de-approving it. And Medicare decided they wouldn't pay for it. So it's a subtle distinction between the two. One of them is not yet FDA approved. The other one was FDA approved and through lack of good data became de-approved. And that's much more of a kiss of death for that particular procedure. However, we hope to resurrect it at some point. And there's more data now coming out of Europe and Japan showing that, hey, maybe this therapy was maligned in the US and maybe it should be reconsidered. So the question is, in the post-stroke pain populations and who responded to the different types of medications and who didn't. To my knowledge, thinking back over the studies, I don't believe there was a gender difference, and there certainly was no evaluation of any sort of genetic factors. These are, I think, fascinating topics. Are people predisposed to having pain? Are they genetically predisposed? Are they behaviorally predisposed? Are there gender differences? Pain is very difficult to study because we don't have any objective measures. It's all subjective. It's unlike Parkinson's or tremor where you can look at the person and say, wow, that's a pretty bad tremor. You can look at somebody, anybody in the audience may be sitting here in terrible, terrible pain, and I wouldn't know it by looking at you. So it's impossible to tell unless you have somebody tell you what it is. And so that's really hampered pain research, but I think we need to look at more of these things. So the question is, your relative, your wife, had coccygeodynia, which is pain in the coccyx area, which was relieved by surgery, by removal of the coccyx. But temporarily, the pain over time recurred. Why does that happen? Well, we looked at some of the mechanisms, some of the potential mechanisms, some of which could be nociceptive in nature, some of which could be neuropathic. Some of those can be sorted out by questioning the patient and trying to sort out what component belongs to which category. And some of it may be that, depending on how long the pain has been there, the nervous system has formed a habit of the pain. And once that happens, it's sometimes difficult to eradicate it. You can change the local milieu somewhat. You can change what's happening in the region where the pain originally came from, but that still may be imprinted on the spinal cord and on the brain. So even if you remove the source of the pain, that chronic pain may persist. And that's where these types of stimulation procedures come in, attacking the pain at the source of its perception rather than at the original source of its generation, which may now be gone. I don't know that that actually answers your question, but do researchers come to them and say, hey, we'd like to have some of your equipment to do this research study, or does Medtronic sponsor the research study? And the answer is both. There are many different ways to accomplish these procedures. The first way, which is probably the simplest way, is to simply use the device off of its labeling. Just in the same way that physicians can prescribe medications off-label, so Neurontin, a great example, which is now prescribed mainly for pain rather than for seizures, was originally a seizure medicine. The pain indication was off-label. So physicians kept prescribing it for pain even though that wasn't labeled that way. The same is true of a medical device. You can use that device off-label if, as a physician, you believe that it's indicated. So this has been the basis of many of these pilot-type studies, is off-label use of the device. However, in order to do an organized type of study that can be published in the medical literature, you have to have good data, and you have to have a protocol, and you have to have it approved by your institutional review board at the institution. And the company has done many of these studies. In fact, Medtronic is now conducting a study of motor cortex stimulation in Europe. They don't want to do it here. I think the FDA is a little bit too stringent for them. But on the other hand, you can do what's called a physician-sponsored investigational device exemption, which means I have applied to the FDA to say, I would like to use this Medtronic device to investigate motor cortex stimulation in this country. Medtronic, will you supply me with the devices? So absolutely both ways are done, and it just depends on what type of study is being done and whether the company thinks it'll be financially profitable, because they're only going to fund studies that they think are going to actually pan out for something in the end, whereas an individual investigator can be a little bit more experimental. So the question was, in reference to my earlier comment about people who can have limb amputations or other traumatic injuries and not feel pain. And I mean, a great example of this is the young surfer who's been in the news who had her arm taken off by a shark. And she was so involved in getting away from the shark that it took her a while to realize that her arm was gone. It was not until she got away from the shark and took stock of the situation that she realized she didn't have an arm anymore. It's very difficult to study these patients because of the circumstances under which these things occur. It's a fast-moving, traumatic, life-or-death situation where you have to get out of there fast, where stopping for just a moment to pay notice to the pain that you're having could mean that you die. So it's tough to get in there with microcatheters to measure concentrations of neurotransmitters in the cerebrospinal fluid or whatever experimental paradigm you're trying to do on the spot. There have been some informal studies of this showing that it's a relatively short-lived effect, and some of it is due to awareness, where as soon as someone realizes that they've lost their limb, the pain immediately occurs. There's some fascinating work done by a neurologist named Ramachandran who looks at the phenomenon called phantom limb pain, in which people have amputations but their limb still hurts. It may be cramped into a fisted posture or some other things. He's developed a mirrored box where if the person puts their remaining limb into the box, for example, puts it into a fist and then opens the fist, and it appears to them, the mirror flipping it so that it's the other hand, the pain will relieve itself. And it happens immediately. So there are huge perceptual overlays which occur with all of this, and we're just starting to get to the bottom of this. The question is about acupuncture, and how does acupuncture work, and can it possibly be real? I have no idea how acupuncture works. I have struggled with thinking about how acupuncture might work, and there are so many different potential possibilities. And one of the most interesting theories that I read recently is that the thalamus, the representation of the body in the thalamus, is folded, and that there are certain points, if you use a microelectrode to record from various parts of the body, there are sudden junctures which occur. For example, you usually go from the thumb to the face without intervening arm. The arm is actually on the opposite side. So you have face, thumb, and then up the arm, which is a very strange representation, but that's how it's done in the brain. So this particular theory is that those foldings in the thalamus or in the body representation correspond to the acupuncture meridians, and that the body is actually divided along those lines, and that by placing a stimulus at that meridian, you can cause whatever abnormal oscillation, whatever abnormal electrical oscillation is causing the pain in the thalamus to abate. Who knows whether that's true or not, but it's certainly a fascinating area to study. I wish I had more time to go to China and actually study with one of the masters of acupuncture to learn more about it, but there's only so many hours in a day.
The preceding program was brought to you by Stanford on iTunes U and is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at itunes.stanford.edu.